American Perspectives continues now on this 40th anniversary of John F. Kennedy's assassination. The late Dr. James Carrico was one of the Parkland Hospital surgeons who tried to save President Kennedy's life. In 1997, he took part in an oral history project conducted by the Sixth Floor Museum at Dealey Plaza. This is the first time this interview has ever been shown on television.
Do you recall when you heard or any thoughts you might have had about him coming to Dallas on a political trip?
I knew he was coming, but there was a lot of, as I'm sure you're aware, really negative statements in the paper about Kennedy and some real hateful stuff in the paper. And we were aware of that, and I thought that was, at the time, I didn't think that was going to help anybody. I didn't have any real thoughts about his coming or any concept
Did that
of danger.
cause, at the hospital, I guess particularly since this was a place where someone who would, what happened would naturally be brought, was there any advanced preparation in any way, just a contingency plan if something happened while the president was in the city?
No, as a matter of fact, one of the big differences in then and now is not only the hospital's preparation, but the Secret Service preparation for presidential visits. At that time, there hadn't been a president assassinated in probably 50 years. I don't know the exact time. And it never really seriously occurred to anybody that the president would actually be harmed, at least to anybody I knew.
You don't know? Oh, go ahead.
As you're well aware, right now, when a president visits any city, the Secret Service precedes him. They select the hospital where he'll go. They select the physician. A whole situation set up. His medical records are made available. He's followed by a paramedic van, etc. In 1963, there was, as far as I know, and I'm pretty sure I know this, no pre-planning. The reason they came to Parkland was simply because they're headed that way, and that's where all the injured patients went. There was no selection of hospital or letting us know his blood type or anything else. So
the Secret Service did not, while they had been around town,
I'm sure, yes, I'm confident they've been
with
around
the
town.
parade route and the
Right.
luncheon arrangements and all this.
Sure.
As far as you know, they never came to
As far as I know, there were no
any of the hospitals.
hospital arrangements, and certainly there was no information provided about the president's health status or anything like that.
Well, zeroing in on the day of November 22nd, 1963, can you kind of reconstruct your day for us? And were you at the hospital overnight? Did you get up that morning? Were you?
Right. I don't remember the early morning. I was actually assigned to Surgery C, which is an elective surgery service, and it was our day to admit patients. So we came in. I'm confident we came in early that morning, made rounds. It was also our clinic day. We didn't operate that day. We had our basically office. So we early in the morning, probably 8:30 or 9, went over to our clinic and started seeing patients, both patients we'd operated on and patients who were being evaluated for new operations. About 11:30, we were getting pretty close to through with our clinic, and we got a call from the emergency room that there were 3 patients down there to be evaluated for admission. This was not President Kennedy. These were 3 patients who had come to Parkland for care. And somebody needed to go down. One of our service needed to go down and start seeing those patients and evaluating them. We also had scheduled a special X-ray where a patient we thought had blood clots in his lungs, and somebody had to go down and participate in doing that X-ray study. The X-ray study sounded like a whole lot more fun than working up 3 patients. So Jerry Gustafson, who was a year ahead of me in the program, and I flipped, and he won the coin flip. He had the privilege of going to do the X-ray study, and I went down to the emergency room to start evaluating the patients that we were going to end up admitting. So that's how I got down to the emergency room.
That's why you were there an hour later, I guess,
Right.
about 12:30.
Just about 12:30, yeah.
Did you recall having any thoughts or any discussion about, oh, gee, we're missing the parade or anything like that, or is that just,
We didn't. The only comment I made, I remember, and I'm not sure if I remember it or I remember Dr. Jenkins talking about it, is Dr. Jenkins commented on the president being in town and hoped everything went well.
So, do you remember sort of exactly how you first heard, what you were doing at the time? A dispatch came in some way?
We were, again, I may be telling you more than you want to hear.
No, we want to hear it all.
The other thing which is different, we talked about how different things are.
Yes.
Right now, as you know, there are mobile intensive care units, really paramedic-equipped vans, EMSs, who pick up injured patients, pick up ill patients. They have direct radio communications with the hospitals. We know what's coming. We can actually help direct their care before the patients get here. In '63, none of that existed. I mean, that all started really about '69. Dallas really did have a very sophisticated system for the time, but it consisted of some of the ambulances having radios which connect with the police dispatcher, and the police dispatcher would then call the hospital and say, X patients are coming. There was frequently some confusion in all that communication with several people. So a lot of times we got a call from the police dispatcher which turned out to be false alarm or overstated. So that leads up to what happened then. One of the nurses came out and told Richard Delaney, who was actually in charge of the emergency room that day, that she had just got a call from the police dispatcher and the president had been shot and was on his way to the hospital.
Only the president?
That was the message I remember. President's been shot, it's on his way to the hospital. The obvious question is what do you do? Well, first thing you do is you don't want to believe it. And with all the misinformation that happened in a situation like that, it was easy to say, yeah, it must be wrong. I mean, it can't be right. But the other thing you do is you start getting ready. So the nurses paged the appropriate people to come help take care of an injured patient. And they paged the surgery team, the rest of the surgery team on call. The chief resident, who was Ron Jones, who's now chief of surgery at Baylor.
Yeah, anyone you can identify by name would be helpful.
Yeah, Malcolm Perry, who was the attending on call that day. Dr. Tom Shires, who was the chief of surgery, he was actually in Galveston giving a paper, but obviously the people in the emergency room didn't know that. But basically, they paged the whole resuscitation team. And we hoped it wasn't we hoped very much it was a false alarm, right? We also there's always a risk that you're going to be calling it a false alarm. Anyway, it seemed like 2 or 3 minutes after we got the message that the door to the emergency room came open and a patient was rolled in, that was Governor Connolly, as a matter of fact. And the reason Governor Connolly was brought in first, I believe, is because he was sitting in the jump seat.
That's the explanation. They had to remove him before the...
Right, so they had to get the governor out of the way, and they brought him in first. So we looked at Governor Connolly, and he had a large wound in the front of his chest and was actually unconscious from the abnormal breathing that results from that large wound. We knew he was hurt badly. We figured we could treat him if that was all was wrong, and we also knew it wasn't the president. It didn't occur to either Delaney or I who it was. We were only interested in who it wasn't.
Yes.
And it was not the president. So we kind of heaved this great sigh of relief and said, maybe it's a Secret Service man, but we'll take care of him. And so we rolled him into trauma room 2, which is really the biggest trauma room. And
did that cause you to divide your team up in any sense in terms of expertise?
Not really, because the beauty of Parkland then and now is the contingency. I mean, you start out, you have a team, but you have tremendous backup, and so you can always get more help and expertise. I guess nothing's always, but you can handle an immense amount of work when you need to.
Yeah.
But basically, Delaney and I both went in the room with him. Then we knew the rest of the support was on the way. The way you treat a wound like that is you plug the hole. Basically, when you breathe, air normally goes in here. If you got a hole this big, air goes in there. So you plug that hole,
Seeing that part.
and
Okay.
you plug that hole, and then the air starts going in the right way, and the governor started waking up. So about that time, another patient was rolled into trauma room 1, and Delaney and I kind of looked at each other, and I'm not sure how we decided, but basically we decided Delaney would stay with the governor, and I'd go see about the patient in the other room. And that's how I ended up being in the president's room.
And in that room, do you recall at that time, who was there exactly when?
Mrs. Kennedy was kind of standing by the door. My recollection is there were 2 men in the room, and I assume they were the driver or Secret Service people. They very rapidly stepped aside when we came in. And
did Miss Kennedy speak to you, or either of these people?
I don't recall any spoken interchange. I think
They were
everybody.
getting out your
Yeah,
way.
they clearly saw we were coming in to take care of things. And Miss Kennedy, as I recall, stood by the door for a long time. And the two gentlemen, I never saw them again that I recognized.
From this point, probably you're going to need as much as you can to give us sort of specific descriptions that a medical professional would recognize, and then
Okay.
maybe also the kind of lay person,
Okay.
like what you saw, how you approached the problem, who was doing what.
Okay. The people that were there were, that I remember, and I'm sure there were others, were myself, a nurse, Diane Bowren, B-O-W-R-E-N, I think, and 2 interns. Marty White, who's now head of the organ bank here in Dallas. There's a lot of people still around, and an oral surgery resident whose name I don't remember right now, oral surgery intern. So that was the team. Your job in a patient who's severely injured, it kind of goes in the steps of do what it takes to keep the patient alive, then you go back and evaluate the injuries more detail and kind of make your long-term plan. And the keeping alive, first you got to have way to breathe. Second, you got to be breathing. Third, your heart's got to be pumping. And fourth, your head's got to be working. Your nervous system's got to be working. So your job is exactly that. You see what's going on with the airway, you see what's going on with breathing, you see what's going on with the circulation, and then you look at neurological function. Usually one person kind of takes charge and everybody else, one team gets some the IVs going to support circulation. The nurse kind of gets the patient undressed and keeps things flowing. And that's pretty much what we did. Marty White and the other intern started doing a cut down on the president's right ankle, I think. Cut down is where you start an IV by actually making an incision and putting a little tube in the vein, or a big tube in the vein, so you can give a lot of blood and fluid if you need to. Diane and I looked at the president overall, saw that he was not breathing. He was breathing very erratically. Call it agonal respiration. It's kind of gasping.
He was. The impression was that he was not dead at this point. He was dead at this point. Or you do this anyway.
Yeah. Well, we looked at him and he still had some breathing. He still had some heartbeat. He had a terrible looking wound, but that wound you kind of really defer to later in terms of evaluating in detail. The principle is, if you got somebody who's got what looks like a terrible injury and is dead, first thing you do is you do the things I talked about. You get the airway going, you get them breathing, then you have time to evaluate the extent of the injury. I've told folks before that the thoughts that I remember going through my head, takes longer to describe them than it took to have them, were first, President's had it. I mean, he's not going to make it. And that was right. Second is, we got to do something. That was the political, the medical thoughts. You know, we can't just let the president die. Third thought was, gosh, what if we get him alive and then he's a vegetable? And the rational thought was, treat this patient like anybody else. Get his airway under control, get him breathing, get his circulation going. Then you can decide about all that other situation. So that's what we did.
Well, you obviously must have really felt, being aware as the president, the sense of responsibility. Were you thinking in terms of history, or just, gosh, this is...
I guess
all this is on my shoulders? Or?
Those brief thoughts, and they, you know, it took a long time to say them. It took about that long to have them. Were the non-medical thoughts, if you will. You know, I mean, I guess my major thoughts were, you know, I really didn't think about the historical impact, what's that's going to do. I said, well, our job is to take care of the president, and that's, we got kind of the reputation of medicine and everything else on our back for a second there. And then that's when the rational thoughts took over and says, okay, we know how to do this. I mean, whether this is the president or whoever, we know how to take care of this guy. And so it became pretty much unemotional and not automatic, but dispassionate at that point.
Professional aspect kicked in, as it did, I think, with law enforcement agents
Sure.
and reporters and everything.
Right. So there was that short, personal, emotional, what am I going to do feeling, and then the professional aspect, as you say, kicked in, and you know what to do. I mean, that's what you're trained to do.
Okay, so kind of go ahead from this
Okay,
point.
so the procedure then is to first see if the president's has an airway, and he really didn't. When we looked at him, he had, we saw this wound up here in the side of his head. Great big
Okay,
wound.
that was readily apparent.
Oh, yeah.
He was laying on his back,
Lay on his back, and
came in, and
that was obvious.
would this be the point you want to kind of illustrate that in terms
Sure.
of where on his head, and if it's,
Yeah.
what did you see?
That's fine. It's kind of out of order medically, but it's probably in
Okay.
order forensically.
Okay.
Yeah, what I remember, and I was telling Dr. Montgomery earlier, with the president laying on his back, I could see the whole wound in his head. And that's important because that really doesn't fit perfectly what we wrote down later. So that meant it had to be in the, it was about right here as I recall, and about as big as I'm showing with my hand, about, you know, a big chunk of bone and scalp missing. And the fact that you could see all of it from the front meant that it involved the parietal bone, which is this big skull bone, and the temporal bone, which is this big skull bone. So we saw that hole. We saw he had a little hole right.
Was that about another sort of controversial thing? Was this above his collar line or slightly below it?
By the time
What do you call it
I
about
looked, Diane, the nurse, had started taking his clothes off, which was her job.
Yes.
So I really don't know
don't know
whether it
exactly
was
what
through the
that
collar
was.
or not, but it was certainly at the collar line. It was just about right there, just to the right of the trachea, and just certainly where his collar should have been.
And she was the one that removed the tie, as
Yeah,
far as you know, or
Yeah, I mean,
I think it was cut off. Is that right?
That's correct.
Would that be
Normal.
standard?
Absolutely. Yeah,
Absolutely normal?
I was doing other stuff. I was
Yes.
lifting his head and stuff, and Diane was doing that. But what you normally do is just take scissors right there,
Oh,
or right
okay.
there. So that both gets the collar and the tie beside the knot, and then you just go right on down, take your shirt off, and then you can see the patient's chest and breathing and all that. So that's Diane Bauer was doing that while I was actually trying to evaluate what we're going to do. I think I just messed up your microphone, did I?
You getting it okay?
Okay.
Yeah, all right.
Anyway, so the next thing, since he really wasn't breathing very well, the next thing to do was try to get him breathing better. And that involved putting in an endotracheal tube, which is
Yes.
a tube which goes through the mouth down into the windpipe, and you can breathe through. So we got that done, and at that time we could see that there was some blood beside the larynx, which is down deep in the throat.
Oh, okay.
There's some
but we're
inside.
Along about here?
Yeah, well, that would be inside. You actually take
okay.
you take a lighted instrument and you look down and see the windpipe inside at the bottom of the throat, and then you put a tube in it. When I looked down there, I could see that there was some bruising and some abnormal swelling over to the right side of the windpipe, and we were able to slip the tube into his trachea and should have been able to breathe better at that point.
That head wound, which you're well aware of, been such a point of controversy and various interpretations and so forth. Did you have any impression at that point, say the direction was a shot that came from the front, from the rear, or just?
No, I mean, the two answers to that. Really didn't, and that's not what you think about at a time like that, although obviously you can't separate thoughts that much. The other is that wound certainly, this wound certainly looked like an exit wound. I mean, just because things were just really blown away.
Okay. Exit towards the back, you're saying?
No,
or
just out.
Just out.
It looks like, I mean, you got wounds that go in, wounds that go out. This was an out. Okay, and that was the what it looked like. But there was nothing about it that would say whether the entrance had come from the front or from the back.
I see.
This looked like where a bullet went out.
I see. Well, once again, I might emphasize, now this was really, in a sense, routine. This team worked with these kind of emergencies every day, right?
Correct.
And so that aspect of it was not that unusual for you.
Correct.
Okay.
And also the order of things. You try to keep the patient alive, you try to treat their wounds, and then in the patients where you're not successful, then we would work with the medical examiner to try to help them figure out the forensics. They were really the forensic experts. We provided the clinical information.
And sort of, as much as we can, clarify the two wounds. Did you ever determine exactly in your own mind where the shoulder or neck wound, and just recently now something's come out about Gerald Ford, who's on the Warren Commission, slightly altering a description there that's kind of stirred the issue again.
Sure. The simple answer is the only wounds we saw were this wound here and this big hole here. We never saw the wounds in the president's back. The medical process is we got his airway going, then we cooked him up to the ventilator and we're trying to help him breathe. Then you got to answer, how's his breathing going? And to answer that, you got to ask, are there any major holes in his chest wall like the governor had in his chest wall, which would impair his breathing. So you don't always roll the patient over to look at that, and particularly in the situation we were in, you don't roll them over. You just put your hands behind the patient's back, down about the belt, and then kind of move up, feeling, to try to make sure that the body cavities are intact. And in doing that, did not detect any big holes, and obviously didn't see what apparently turned out to be two small wounds, one kind of over the shoulder and one back here, way back in the lower back of the head. So we never saw those two wounds in the back. And that's a long answer to a short question.
No, well, we probably need long answers to almost all the questions in that sense.
And the reason we didn't is that was, at least at that point, that was not part of the appropriate medical exam to try to find. That would actually required rolling the patient over, washing blood off, etc. And clearly in somebody that you're struggling to keep alive, you don't do that.
Is there anything else we need to fill in here before, say, the point where it was determined he was dead or was declared dead, and who called that shot?
Not really, or we can fill, I mean, there's some medical stuff which we could fill in briefly. After we got the tube in, tried to breathe for him, he still wasn't breathing very well. And his heart rate was slowing down, and his heart actually stopped. When his heart stopped, by that time, Dr. Perry, Dr. Jones, Dr. Jenkins, Dr. Giesecke, the assistant chief of anesthesia, Dr. Baxter, a number of people were there. They started CPR. Because there was concerns about whether he had tension pneumothorax or not, and we hadn't had time to get an x-ray, they actually put chest tubes in both chests. Those are things so if you do have a collapsed lung, it can expand it and you can breathe. Concern about whether or not the endotracheal tube was actually where it should be because of the tracheal wound. So Dr. Perry did a tracheostomy, which is where you make an incision in the neck to get a shorter tube in more directly into the trachea, so there's no question it's in place. And I guess all that is important in terms of
Certainly.
explaining what was done and a lot of things that happened in that 20 minutes. As I'm sure you're aware, the tracheostomy wound was right through this wound in the neck, and that caused some confusion later. But that's where a tracheostomy wound had to be. Then we gave him some steroids because we had remembered from some stuff in the press that he probably had abnormal adrenal glands. And,
But you've already covered this in the sense, and you talked about the Secret Service. You didn't have his medical record there.
That's correct.
On hand as you would have today.
Correct. So at this point we had gotten his airway under control, gotten him breathing, trying to make his circulation better. His circulation wasn't getting better; it was getting worse. His heart had stopped. But we'd done all we could do to get things stable. Kemp Clark, who is the chief of neurosurgery, evaluated the situation, evaluated the head wound in much more detail than I did. And then Kemp Clark was the one the chief of neurosurgery was the one that actually pronounced him dead.
And this was some 20 minutes later?
About, yeah.
Something like that?
Something like that.
The priest had come in?
Actually, Dr. Clark said, he basically said it's time to stop the resuscitation. He would, for whatever reason, the decision made not to actually pronounce the president dead until after the priest had come in and given him the last rites. So we stopped treatment, but Dr. Clark didn't pronounce him until after the last rites.
Do you recall who notified Mrs. Kennedy? Was that one of the medical team, or did you?
I don't know.
You don't recall that?
No.
And so from that point, what happened?
Well, from that point, my job was, the medical part, I guess the patient care part of my job was over. Had two things to do. One is we had to as we do for all patients, write a brief report in the emergency room records of the treatment and what we saw and what we did. And my other job was to find those three patients who I had been working on before the president came in and take care of them. We did sit down. I remember one thing, which probably of note. Walked out of the trauma room 1 and been to the big emergency room, which 20 minutes before had been a big city-county emergency room full of people being treated, etc. All the patients were gone when I walked out. They'd been moved elsewhere. The people in the room were by and large men with coats off, shirts and ties on, and guns on their hip. And a couple were talking on the phone to Washington, and that's when I guess really the whole thing kind of hit me. You know, it just up till then, except for that brief moment, it had been professional work. And I walked there and realized that not only had my little world changed, but what the whole world had changed, and it changed that quick. So that I was smoked at that time, as a lot of us did. We thought it was a cute thing to do, right? So I started to light a cigarette. And imagine lighting a cigarette in an emergency room now. That was common in 1963. So I started to light a cigarette and realized I was trembling so that I really couldn't had trouble getting the match to the cigarette. But kind of got that under control and sat down to write my recollections. And again,
This was just individually, was not the team? Or
each physician writes their own report independently. There's no proscription against exchanging information, and you know, I mean, I'm sure you could ask the guy next to you, where was that wound, what was involved, and I remember if we did. I do not remember if we did that or not, but we wrote our records. And
also kind of thinking in terms of any conversation you might have had about the effect on others is that being part of that process, did y'all talk about it later, if not then, or?
You mean just how everybody was dealing with it?
Yeah, how it affected you personally?
Yeah. I'm sure we talked about it some, but we didn't talk about it as a group, and there was none of the debriefing which would happen now. But it was, we just kind of went back to work. I mean, we finished writing our reports. As you know, by the time we finished writing our reports, they had taken the president's body away, so our reports did not get to Bethesda for time for the autopsy.
What do you know about that issue? There's a big conflict about removing the body. State law, the autopsy should have been done here. At the time, did that seem significant to you, that what happened, that it was removed?
No, I was a little surprised in a professional sense, and kind of in this sense. As I said, what would usually have happened with a patient who came in and died of a gunshot wound is we would have tried to keep him alive. We'd have done whatever we had to do medically. We probably would have spent more time after the patient was dead kind of trying to figure out the forensics ourselves than we did with the president, but it didn't seem appropriate to do that with the president. But it really wouldn't have mattered, because when Earl Rose, who was the new county medical examiner, did his autopsy, if he had questions about the treatment, he would call us. Matter of fact, he'd frequently call us down just to teach us. He'd call the house staff and say, okay, here's this patient you treated, tell me what you did, and then let me show you how to recognize exit wounds, entrance wounds, etc. So we kind of all assumed that there was no reason to roll the president over, that Earl Rose would be doing the autopsy. When the president was taken away, we realized, gee, the body's gone, Earl's not going to do the autopsy, and these guys are not going to have any medical records to go by. But that was kind of the medical surprise, if you will. Didn't think about why they would have done that.
It wasn't related to his competency as a anything like that?
No, zero. I mean, Earl Rose was and I think is still recognized as one of the really outstanding forensic pathologists in the country. But the reason we're given, and it makes sense, is that President Johnson was not willing to leave Dallas on Air Force One, President Kennedy's plane, without President Kennedy's body.
So you think it was probably his decision as opposed to Mrs. Kennedy, or the two of you? Don't.
I really don't know.
Supposition on your part.
Yeah. What I've heard is
yes,
that President Johnson wouldn't leave without President Kennedy's body, and I don't know any facts, but it makes sense. I mean, he was a pretty shrewd politician, and you can imagine the impact of people saying, boy, he not only took the president's job, he took his plane, he left town, left the president in this mess.
Well, I recall in the interview we did with Henry Wade, who was the district attorney at the time, and just kind of dismissed that as, he said, well, the only fine was $100 if you removed the body from the state of Texas. Was not that big a deal from that point of view.
No, the law is, as I understand it, that a murder here, the examination has to be done here. But gosh, it was a president. There's no laws about shot presidents, and it's no big. I mean, if I'd have been a Secret Service man, I think I'd done the same thing. And I'd gotten that body out of here and gotten President Johnson out of here, because they didn't know if it was this was a Russian plot. They didn't know what was going on. So their job was to get Johnson to safety.
When the autopsy was performed, the information that came back to you or to Dallas, however that came about, what was your reaction then? Do you remember?
Well, the first, we had Friday night had been busy with taking care of those 3 patients that were waiting, and that. Well,
I want to get the details of that weekend too, but
sure.
just kind of while we're on this subject.
Saturday morning was our mortality and morbidity conference. Every Saturday morning we sat down and went through all the cases we'd done during the week, and anything that had gone wrong, we analyzed what had gone wrong, and which is a fairly typical medical approach to things. So we were in our Saturday morning conference when the phone rang, and it was the pathologist in Bethesda trying to get hold of Dr. Malcolm Perry to get some medical information. And that was the first time, I think, that the pathologist in Bethesda knew that there was a wound here, because all they saw apparently was a hole here, a little hole here, a big hole here, and a tracheostomy wound. And since they didn't have any medical records, they couldn't figure out how in the world 3 holes connected. So they called Malcolm, and that's when they told him that there was, that these other 2 wounds were there. And that's when it kind of began to make sense that bullet went in here, came out here, nicked his trachea, maybe he hurt his spinal cord, didn't kill him. And then the second bullet went in here, hit the bones inside his head, but came out here and blew that big hole. And so that was the first time we could really put things together in a way that made sense.
And what you were hearing from them and after those discussions, that did make sense to you?
Yes.
Excuse me.
Because before we had seen this hole and this hole, didn't know whether there were holes back here or not, and we were trying to speculate how these 2 could connect, and it's hard to make any sense out of that.
What about also the controversy about the bullet that went through President Kennedy, went into Governor Connally? Out of your experience with our gunshot wounds and everything, is this feasible to you?
Yes, it is, and there's been a lot of analysis on that on both sides, and haven't looked into it in detail, but certainly the concept that this first bullet went through here and really hit very little other than muscle in the side of the trachea, which is soft, then went into Governor Connally's back, and the first time it really discharged a lot of his energy was coming out through his chest here. Then I guess it hit his right or left wrist, I forgot. It must have been his right wrist, and hurt the bone, but it really, if you look, that wasn't a terrible destructive wound like this thing was, and then kind of splatted into his thigh. That sounds like a lot of traveling for a bullet, but it's certainly plausible. I mean, bullets do strange things. And that was unlike some of the movie suggesting it bounced all over the place. That was pretty much a straight line.
You were in that first room working with Dr. Delaney.
Mm-hmm.
Did you ever realize it was Connally in there?
Not until later. I mean.
So you left that room to go to the next body, and you didn't know it was the governor.
Right.
When did you realize it was Kennedy in the other room?
Oh, as soon as I walked in the door, because that's who we were looking for. Right. I mean, what's the old story? You see what you're looking for.
Uh-huh.
We were looking for the president. Connally wasn't him, and I got to say this very carefully. It didn't really matter who that was, did it? In terms of treating him, we were going to treat him same no matter who. And then when I walked in the room and saw the president, it was obvious it was him, because that was what the tapes were running to look for, and of course he was very recognizable.
Tell us a little bit about the Addison's disease and what was out in the medical community and what you knew about it.
Yeah. Well, what I know in retrospect, or at least what I believe, is that President Kennedy had some severe arthritis, etc., and had been put on steroids for pain relief or for relief of inflammation. And when you put people on big doses of steroids long enough, the adrenal glands quit responding. And apparently his adrenal glands had quit responding. Whether he had any primary problem with his adrenals, I guess we'll never know, because they were not part of the autopsy. But the way we kind of had some hint that something was going on, as I say, we were aware of all the noise in the press, or some of the noise in the press. Somewhere in Congress within a few months before the president's assassination, there had been a discussion where somebody had said that the president had Addison's disease, and Bobby Kennedy had said, Addison's disease is caused by tuberculosis. My brother's never had tuberculosis, therefore my brother doesn't have Addison's disease. Well, the logic is there, but the logic to a country boy is that that's a little evasive, right? And so our was kind of common knowledge that the president had adrenal
Well, that had
insufficiency.
been in the press, I can recall that.
Yeah.
Yes, those rumors.
So those rumors that he had renal insufficiency were around, and so that was we happen to remember that, and so we gave him steroids, hydrocortisone, early in his treatment. Normally, you would not do that to somebody who was in shock, but if their adrenal glands weren't working, you would. So that's
But actually, tuberculosis is not, Addison's disease and tuberculosis are not connected
well.
medically.
Medicine's funny business. See, there are. I know you guys, we're tape's running short. There's physiologic diagnosis, adrenal insufficiency. Okay, that means adrenals aren't working. Then we sometimes name diseases, right? Addison's disease is named after Dr. Addison. And Dr. Addison described adrenal insufficiency in people who had had tuberculosis and destroyed their adrenal glands. So literally speaking, Addison's disease is adrenal insufficiency caused by tuberculosis. And literally speaking, President Kennedy did not have Addison's disease, but he still had adrenal insufficiency. See the difference? It's eponyms versus physiologic description.
I've heard that had you not done that, had you not given him those injections for that Addison's disease, that even if you had saved him, he would have had problems.
Well, what probably would have happened if he really had adrenal insufficiency, and we think he did, that he never would have responded to the shock. He never would have come out of shock, or at least it would have been much more difficult to get his circulation going. Because what the adrenals do when you get stressed is they kick out cortisone and other things which help your body respond. So it would have made it much more difficult for him to come out of shock. But had he lived over it, then he would have still needed steroids long term. But there would have been no injury, any organ injury from not getting the steroids. But they would have been important to getting him to survive.
And you've been a little modest. It really was you who remembered this in
that
team.
Yeah, but that's what a team's about. I mean, everybody pitches in, and actually he would have gotten him anyway, because Admiral Berkeley came in late in the resuscitation, carrying vials of hydrocortisone to make sure the president got them. His car had been separated.
Who was Admiral?
Admiral Berkeley was the president's personal physician.
Was traveling with him. Yes.
Traveling with him, but he was 2 or 3 cars back, so they got separated in the traffic, etc., and all the melee. And
Well,
so,
I think the rest of the motorcade diverted to the trade center.
Yes, yeah.
So, and then people had to scramble to get over to the
Right.
hospital.
So it took him. I know it was late in the resuscitation when he came and said, "Give the president hydrocortisone," but then it was too late, but then we'd already given it. But
And he was pleased to note that you
yeah,
already
right.
did it.
One of the other issues with some of the conspiracy theorists relates to how his body was removed from Parkland, and question about a switch of a body bag or something.
Right.
You know anything about that at all?
I really don't. I mean,
You were not in the room when he
wasn't in the room when he left. I wasn't even aware that when he left. I was just aware that he had left. There's one thing which Dr. Montgomery and I were talking about, which is an inaccuracy in our records, which
Well, let's clarify that. That was kind of the next step in this,
okay.
was for you to add anything we haven't touched on, certainly.
If you look at what we wrote, we said that the scalp wound was occipital parietal, which an occipital bone is way back in the back, in the parietal bones here. Again, those notes were written after the president had gone. We were kind of trying to remember. And it didn't occur to us that this was a big forensic record we were writing. We thought we were writing a medical record. So, could have said head wound, that would have been a lot better. If the occipital bone's way back here and the president's laying on that, you couldn't see the whole wound, right?
And could you kind of turn your head and kind of show?
Matter of fact, there's a little knot on the back of your head,
Oh, okay.
and that's kind of where the occipital bone reaches its peak, right in the middle. Everybody's a little knot on the back of their head.
Okay.
So occipital parietal would have really been right back there. And literally speaking, number one, that would have been very difficult to explain as a exit wound if you were shot from the back. And number two, you couldn't have seen it with the patient lying on his back on a gurney. So if the recollection that we could see the whole wound from the front's accurate, and I think it is, then what we should have written down was temporal parietal rather than occipito-parietal. Part of that is learning through the years that a medical record is much more than a medical record. It becomes a forensic record. Sometimes it's a billing record. So that I wish we'd have been more precise in our writing. We weren't.